Good morning, everybody. Thanks, Sue, for that very nice introduction. Yeah, I started my training in 1988. So brought up 2 children single-handedly, tried to do my degree when they were younger and ended up screaming at them and hadn't even started the essay. So I decided to do the degree later on. I've just got 2-1, so I'm graduating next month. Master's next, so there's no stopping me now. I'm going to talk about optimal cord clamping. A lot of this, thank you, is not rocket science, and we talk about optimal cord clamping for every baby because optimal for each baby is different depending on the scenario. Initially, when I trained, we had immediate cord clamping. We were all taught to do immediate cord clamping, and if we didn't get those clamps, then we got our hands slapped. That's the way we were trained in those days, and there's a lot of people nodding their heads here. Some people get really upset about delayed cord clamping and optimal cord clamping. At the time when we were training, delayed cord clamping, immediate cord clamping was actually normal cord clamping, so delayed came first. Optimal cord clamping has gone, and we're just moving on a little bit more now. So I'll start with the presentation. It's not new, is this? We were saying that Caleb was discussing pre-BC, and Aristotle actually wrote in 3300 BC that frequently the child appears to be born dead or is feeble, but before tying the cord, a flux of blood occurs into the cord and adjacent parts. Some nurses squeeze the blood into the baby's body, and at once the baby, who had previously been drained of blood, comes to life again. Other people have written about it as well, but because we've only got 20 minutes, I'm trying to cram everything in. There's a lot of information here, so hold on to your seats. So immediate cord clamping came in the 1960s and 70s when an oxytocin drug were introduced and immediate cord clamping became routine practice. No thought at the time was actually given to the effect of immediate cord clamping on the fetus, and there isn't, and there never has been, and there isn't now, any evidence to support immediate cord clamping for any baby. The evidence that's coming through now is actually proving that we may be causing harm, well, we are causing harm. Some people get quite confused about the actual physiology. And this picture was on Facebook a while ago, and it just shows a complete circuit and baby safety net, that the placenta and the baby are one circuit. A lot of people seem to think that the blood comes through from the mum into the baby, and we're actually, you know, the blood that's left in the placenta belongs to mum. It doesn't actually, the whole circuit, it actually belongs to the baby. I was told, I started talking about this in 2005, and in about 2012, I was actually asked to be quiet about trying to change practice from immediately to optimal cord clamping. And my response to that was to set up a Facebook page, and we've now got 25,000 likers. And we went from 6,000 likers to 24,000 likers in about 5 days when I put this photograph on. So I don't know what happened, but you can see it's a really nice picture, and it does illustrate the circuit quite nicely. Everybody is welcome to the presentation, and I'm also, people can contact me on Facebook. I put my contact details on at the end, so if anybody's got any questions or they want any help, I get lots of students asking for information about dissertations and ideas and research proposals. Please get in touch with me. This baby, you can see there that this baby's definitely had immediate cord clamping. The baby was 10 pounds and should have been about 10.5. 30% of the blood volume is actually left in the placenta. At least 30% of the blood volume is left in the placenta with immediate cord clamping, and you can see that this baby would have been bigger. This is actually the same cord. This is a baby that was born, and it belongs to a baby in Australia. Mum is Kate Emerson. She's got 4 children. Her second child had a Nuchal Cord cut and shoulder dystocia, and he's got profound autism. She's a really intelligent woman. She's just qualified as a nurse as well, and she's gone into the research pathways. And this is her 3rd baby, where she's got the actual cord and shows what it's like when it's actually finished its process, which is a new campaign that we call Which is Wait for White. So when there's no risk, we shouldn't be doing any interventions at all. We should just be leaving the cord to finish its job whilst baby's in skin to skin. But I'll talk a little bit about risk management as well. Talk about Professor Judith Mercer. She's a midwife and lead expert of optimal cord clamping in the USA, and I talk about her because she's my heroine, and also because as midwives we can do an awful lot. We are, you know, she started off in a very male-dominated medical model of midwifery and realised that immediate cord clamping was wrong in the 1990s, and knew that she wasn't going to be able to change practice unless she went down the academic route, and she's now done so much work. And if anybody needs any information about cord clamping, she's got a really good article called Rethinking Placental Transfusion that covers every aspect. I've met her a few times, and she actually stayed at my house in April. She came to stay with us, and she was in my bedroom, and my son was getting really excited about it. He couldn't understand why we were getting excited, and I said it was like the equivalent of having Metallica's lead singer sleeping in your spare bedroom. And she's really nice. She's 75 and she's so humble, and she said, you know, we are midwives. She said, we have a fantastic job and we can change things. And we all have the same aim and objective of making things better for mums and babies. And we shouldn't compete, we should all work together, which we have to do. She showed that the biggest benefits for delayed cord clamping were for premature babies. So it decreases the risk of intraventricular hemorrhage, necrotizing enterocolitis, late onset sepsis, need for blood transfusions, need for ventilation. It increases hematocrit, hemoglobin, blood pressure, cerebral, lung and organ oxygenation, red blood cell flow and breastfeeding duration. We know that neurological development with delayed cord clamping is better. Just talk about a bit of research in a minute, but recent animal and human studies suggest that early cord clamping before the onset of spontaneous respirations appears to adversely affect cerebral perfusion during fetal to neonatal transition. Mercer demonstrates improved motor function at 18 to 22 months, the corrected age, with delayed cord clamping. Raby 2016 demonstrated similar outcomes. And Ulla Anderson, who is a Swedish paediatrician who's done a lot of research and is doing a big study at the moment, in 2015 demonstrated that improved fine motor skills and social domain scores at age of 4. When this result came out, we thought this would really change global perspective on delayed cord clamping, but it didn't. The papers, instead of interpreting it as immediate cord clamping can damage your child's neurological health, actually turned it around and said that delayed cord clamping will improve your child's skills. So it didn't really have that impact. Ulla is actually doing a big study in Nepal at the moment, and the year study showed that children that have immediate cord clamping have got quite severe, a lot of the children have got quite severe anemia, and anemia, iron deficiency anemia impacts with neurological and behavioural in children. So is it ethical to do a study in Nepal? You certainly wouldn't be able to do it in the UK now or the European countries, so there were studies from Nepal. But unfortunately, we need evidence to prove things, and that's we're awaiting those results. This should be on the board of every delivery suite in the world, really. It's Diane Farrar, who was a midwife from Bradford, who did a study in 2010 that weighed babies with the cord intact for 5 minutes and assessed placental transfusion. And you can see that this baby, when it was born, was 3.4, and after 5 minutes, it's 3.6. The increased weight gain was 214 grams, up to 214 grams in each baby relieving the cord, which is a phenomenal amount. It's 7 ounces. Changes in guidelines. When I first started talking about this, all the guidelines recommended immediate cord clamping. World Health Organization were first on the mark with 2007, and they changed it to recommend that umbilical cord clamping should occur with all babies, and then changed it in 2012 to say where possible, delayed cord clamping should be performed during the provision of essential neonatal care, which I'll talk a little bit about in a minute. RCOG 2009 changed their guidelines to say that cords should not be clamped earlier than necessary based on clinical assessment. Royal College of Midwives 2012 changed theirs and said that midwives, which was at the time I was a bit disappointed because they didn't say how many minutes or what delay, but they actually brought in as well that midwives should be competent in both active management and physiological management, because again in my training nearly all the deliveries I saw were active management. Very few women actually got physiological management. And so they killed 2 birds with one stone, really. They talked about delayed cord clamping and they moved to physiological management. And then NICE in 2014 said do not clamp the cord earlier than 1 minute from the birth of a baby unless the cord or the baby has a heart rate below 60 beats a minute. We're not getting faster. That is very, very few babies. So the majority of babies should be getting at least 1 minute. Talk about Wait for White, which is our campaign, and we're saying, where there's low risk and, put the baby on the chest. I work at a hospital where they do delayed cord clamping. I had a grandson in January. I didn't, my son's girlfriend had a baby. And we got 14 minutes. Because we didn't do physiological 3rd stage because she had borderline platelets. So again, it's risk management. But we did wait until the cord had stopped pulsating before we give the oxytocin drug, and it was 14 minutes. But I'll tell you, boy, they were twitchy about this baby. They were saying, it's a bit pink, and I have to say it was a bit pink. But it just shows that, we're so heads up about 1 to 5 minutes because NICE said so. But anything that you do before that cord stops pulsating is an intervention. I talk a little about another hospital who actually won't do a guideline for delayed cord clamping because they said immediate cord clamping is the intervention, and they should be doing a guideline for immediate cord clamping. It would be like doing a guideline to say why not to do an episiotomy. So that's just something to think about. So informed choice, that's so important. So many women, we talk about the cord banking. You know, I'm hearing more and more now about hospitals where every woman is given a leaflet about banking the baby's cord blood, but they're not given information about delayed cord clamping. So they're all signing up to give away the baby's blood, but they don't actually know about the evidence that supports delaying cord clamping. So please take that on board and, you know, make sure that these women are given, or parents are given this information. Because if they were given the information, they wouldn't be banking the baby's cord blood or giving it away to other babies. They would be putting it in their baby. So informed choice is really important, we know that, but quite often we do rhetorical questions, and I've been guilty of that myself in the past. So delayed cord clamping as part of active or physiological management. Physiological third stage should be considered as default management in the absence of pregnancy complications. Neonatal resuscitation with the umbilical cord intact wherever possible. So active management, we know oxytocin drug following delivery of the baby. Immediate recommended by NICE, but autonomous practice. If you've got many midwives delay administration or have interpreted the guidelines to say that they're not going to give oxytocin until the cord stop pulsating. New Zealand, NICE said that it's okay to give the oxytocin, and they say that you know, the Cochrane said that it's okay. But New Zealand actually have a policy that they won't give the oxytocin drug before the cord stop has been clamped, because they said they haven't got the evidence to prove that it is completely safe. And are we falling into the same trap of doing something just because we think it's okay, but we haven't actually got the evidence there. Controlled cord traction, and 2010 Cochrane review showed that timing of oxytocin made no significant difference to the risk of PPH. So if there's no resus and no bleeding, there's no rush. But again, assessing and managing the risk of PPH is important. If you get a woman who is twins or long labour or has had previous PPH, you'd be thinking and looking at that woman in a holistic manner and assessing that risk management. We had somebody did a study on a maternity unit where they realised that their PPHs were actually higher than the national average, and it's because they weren't looking at the women and managing that woman in her own entirety. They were doing physiological third stage for everybody, and when they actually started looking at it, had a bit more education, theirs dropped down to below average. So again, what's the rush? No resus, no bleeding, no rush. And in the majority of cases, that is adequate. We should be just keeping our hands off. Nuchal Cord, David Hutchin, well, we're all really in this, but David Hutchin is very into the Nuchal Cord because, again, I was trained at a time when we used to look for students, we used to look for the cord, and if we found a cord, we used to clamp and cut. There's a few more nodding heads here. And we all did that. And now I look back and I think, gosh, you know, the baby comes through the vagina and is squeezed, and a lot of the blood is actually in the placenta. And as the baby comes out, it fills back up with blood. And if we've cut that Nuchal Cord, the baby's lost all that blood. Somersault manoeuvre, babies can deliver through the cord. They will deliver through the cord. Somebody pointed out quite rightly that this should actually be on its end, so that if you've got gravity help that baby out, you're much more likely to get a more positive delivery, and the baby can somersault through the cord. Obstacles for delayed cord clamping. People used to say, well, we need blood gases, and doctors are very keen on this. You know, we need the blood gases, therefore we've got to do immediate cord clamping. You can do it on a pulsating cord, it's not a problem at all. You use a fine but a small needle, orange needle with a small syringe. You don't need an awful lot. Just the same as you take blood off an adult. Take the blood, gentle pressure. I've never seen spasm on a cord, so, you know, and people report that you don't get spasm. You're supposed to be minimal handling, but you can do cord blood. Quick talk about placental transfusion, a review by Anup Katharia, who has done an awful lot of work on PREMS and resuscitation, but he's done one on milking as well, and he did a review of delayed cord clamping, intact cord milking and cut cord milking. Does anybody know what milking is? I'm sorry to myself just. Milking 2 to 4 times gives the same benefit as delayed cord clamping, so it's holding the cord and stripping it, holding the cord and stripping it. So if you've got a baby that's in distress, or you think, you know, rather than do immediate cord clamping, a few strips of the cord will give that baby a bonus, a bolus that they won't get otherwise. And placental transfusion should be considered at every delivery, as it can have marked impact on the outcome of newborns. There's no increase in jaundice or polycythemia. Some people were concerned that this would overload the baby, but if you think you've got this baby that's been carrying blood all the way through the placenta, all the way through its body and back out, they're quite robust. And to have a bit more fluid is better than no fluid at all. The benefits outweigh, well, there isn't any. Anup's done a lot of work, and it's worth looking at his work if you're interested in this field. Increased jaundice. In 8 studies involving over 1,000 neonates, there were no significant difference in the risk of jaundice within 24 to 48 hours. And in the most recent meta-analysis of 1,828 infants in 5 studies, there was no significant differences in clinical jaundice. And I would certainly be, even if there was jaundice, I'd certainly be risking a bit of jaundice for my baby to get his full blood entitlement. Gentle sections. Becoming more, a lot of parents write to me and say they're having a cesarean section, they're getting a lot of resistance from the consultants or the doctors that are doing it. But there's an awful lot of doctors that are very, very on board with this. In fact, I've had more positive work with the doctors about changing practice because they can see the benefits. And you only need one parent to really, really push the doctors to do delayed cord clamping, and then they stand back in theatre and they see this baby on the mum's lap actually resuscitate itself and pink up before they change practice. And Leeds, where I work now, all the elective sections are done with delayed cord clamping. So delayed cord clamping or milking, if you've got a baby that's compromised, milking, warm towel, bedside resuscitation if necessary. And waiting to clamp the umbilical cord for 30 seconds after elective section results in higher iron stores at 4 months of age compared with early cord clamping after vaginal birth. And that's Uller Anderson again. Not so gentle sections. You can see this baby here looks a bit stunned, a little bit prem. Looks like it could have done with a little bit more time with the cord intact. Lotus sections, it is possible. In fact, they were quite easy really to deliver the baby and then scoop the placenta out at the same time. Has been done, I think, about 5 years ago at Leeds. I would love to have been a fly on the wall. But quick word about European resuscitation guidelines. For uncompromised babies, a delay in cord clamping of at least 1 minute from the complete delivery of the infant is now recommended for term babies. And we're saying really we're trying to change practice from the first 60 seconds after a baby's born. We dry the baby and we stimulate the baby for 30 seconds and assess, and then we give 5 rescue breaths. We need to be changing practice so that is done with the cord intact. We realise the biggest obstacle would be for premature and compromised babies, would be the rush to clamp and cut the cord and take the baby to the resuscitator. And we developed in 2010 a bedside resuscitator, a team of consultants and myself, which is a basic life start. I'm going to whiz through this a little bit because we're running out of time. But it means that mums can have the baby, well, the babies can have an intact cord with resuscitation for the first few minutes. There was a neonatal resuscitation conference in Newcastle, and we were saying, when you deliver a baby, we're saying it's so important to try and get that first minute with the cord intact. Because if you had a baby that was having a deceleration, we wouldn't go in and cut the umbilical cord. We would leave it because we know that the placenta is quite capable of resuscitating that baby itself. So maybe we should be thinking about a new ABC of resuscitation, which is airway, breathing, and then clamp. Because at the moment, most of the practice is actually clamp, airway, breathing, and that baby's lost 30% of its volume. So conclusions, intact cord resuscitation is possible. Bedside resuscitation is acceptable. We're saying about the livestock trolley that we developed, it allows formal evaluation of deferred cord clamping, and with very premature babies, resuscitation and deferred cord clamping are not mutually exclusive options. Said a little bit about cord blood donation. It's baby's blood. If these parents were really given informed choice about, that they're doing early cord clamping on those babies, even if they get a minute, it may affect their baby's neurological development. They're not going to be doing it. You can do optimal cord clamping and donation, or saving the blood. And there's more of the banks now are doing family sort of groups where they will save a certain amount of blood for research. So that is coming in. And with the pathology, it's getting to where you don't need much blood at all. Some companies want as much as possible, and I did talk to a man who's asked to speak to me. They got 280 mils off a baby in Abu Dhabi. I said, did that baby get his, what's it doing now? And they were really proud. Hannah Tizard, students, she's a student, she's just coming up for qualifying, and in the first year she developed these little stickers that you put on the notes, and she calls it the Blood to Baby campaign, which is supported by Indie Inspiration, who've done the basics trolley. If anybody wants these free resources, you can get in touch with the website, which is www.bloodtobaby, and they will send it out so you can get the posters and postcards and little stickers to put on your notes, and they've gone all over the world. They're the stickers, and her infographic has been accepted by NICE. And they're my details. So if anybody wants any help or any further questions, please get in touch with me. Sorry, that's really quick.